Welcome, everybody. I want to begin the webinar by thanking all of you who are online today. I promise that the next half an hour will be time well spent. It's truly an honor to have Dr. Jason Siefferman as our guest today. Dr. Siefferman is a board-certified expert in pain medicine and rehabilitation, PM&R, expert in headache medicine and interventional pain medicine. He is also a clinical assistant professor at NYU School of Medicine. His private practice, Manhattan Pain Medicine, offers a comprehensive, holistic approach to diagnosis, treatment, and management of pain-related conditions. Dr. Siefferman is also a speaker and author of several academic articles on chronic pain treatment modalities and care delivery through the lens of his multidisciplinary approach. He's given dozens of presentations, peer-reviewed journal articles, and numerous book chapters on topics ranging from back pain to pain among older adults to even pain and patient safety in the clinical setting. He runs a busy, wonderful multi-specialty practice in New York City called Manhattan Pain Medicine. Dr. Siefferman is a leading national expert in pain medicine, a relatively new specialty, physical medicine and rehab. Welcome, Dr. Siefferman.
Thank you. Thank you for having me and for those kind words.
Please feel free to leave questions in the chat, and we'll try to answer them in the next 30 minutes that we have. Dr. Siefferman, how has interventional pain management evolved over the past decade in terms of minimally invasive techniques, and which advancements do you consider most significant for patient outcomes?
So this is an interesting question because I think the biggest advancement in pain management over the past decade has not been in technology evolution, it's been in practice evolution. To look at the technology specifically, everything that we have now, the spinal cord stimulators, peripheral nerve stimulators, sacroiliac joint fusion, microdiscectomy techniques, we had all of that 10 years ago, and it really hasn't changed dramatically. There's been broader adaptation, more doctors are doing it, but the technology itself really hasn't evolved much. What has evolved is the old-fashioned standard practice of getting the diagnosis right. 10 years ago, 15 years ago, pain management doctors generally would look at imaging. They would see if there's a disc herniation, there's something wrong on the imaging. If patient has pain that correlates with that, they treat. What's changed in the past 10 years? Doctors are readopting physical examination. They're getting more specific and precise about making sure that the thing on the imaging is actually the source of pain. Several studies have come out that show 50% of people have lumbar disc herniations, 90% of people have cervical disc herniations, even without neck pain. So just knowing what the actual source of the pain is, confirming that it's the source of the pain before jumping to a treatment modality has really been the evolution in recent time, which is, it's funny because physical exam skills are the oldest tool in our toolbox, but they're gaining renewed respect for the value they have in diagnostic specificity. What has changed in terms of technology over the past decade are the regenerative medicine techniques. And this goes hand in hand with the diagnostic specificity because diagnosis can have many layers to it. Let's say somebody has low back pain, they have a disc herniation in the back. Great. You can say that that disc herniation may be contributing to the source of back pain. We can do diagnostic injections to confirm it, but is that the end of the diagnostic process? We don't know why that disc is herniated. We don't know why that disc has not healed on its own. The next level to the diagnostic process is really understanding the why of how this came to happen. Because even if we treat that disc, if we don't treat the reason for that disc herniating in the first place, it's going to reoccur. It's not going to heal. Any treatment that I render is going to be temporary and not durable. So delving deeper into the diagnostic process to really understand how that disc came to herniate. If it was an accident, sure, that makes sense, singular event. But if it wasn't, if it was slow progressive use over time, if it's the way the patient uses their body, the way they bend, the way they twist, the way they do their job, if we don't actually change that process, they're not going to get any better. And so that's when we reach out to our other specialties like physical therapy and really try to put everything together to get the core problem treated. And sorry, to speak of the regenerative medicine, go ahead.
And Dr. Siefferman, when you talk about getting the diagnosis right, in some ways, maybe step one, we often see people diagnosing themselves, people saying, my primary care doctor thinks, or my cousin was a podiatrist in Wisconsin and they think I have X, or even an orthopedic surgeon. How is your training as a physical medicine and rehab doctor and the tools you have different than others around getting the diagnosis right?
That's a little bit of a difficult question. So each specialty has their own sort of doctrine that gets passed along generation to generation. And there's a scope of practice and there's an approach to problem solving that is specific to the specialty. One thing about PM&R is we sort of span different body systems. So, orthopedists, they work with joints, muscles, bones, and that's kind of the extent of it, right? Like neurologists will work with the brain, spine, peripheral nerves. That's kind of the extent of it. PM&R deals with function as a primary outcome. So we're really looking at the mechanics of the body, which incorporates the bones, the joints, the muscles, the nerves, the brain, the psychology, even skincare at times folds into that. So the core of PM&R training is really someone who's had a devastating injury, like a brain injury, a stroke, spinal cord injury, major trauma, multiple fractures, things like that, and the process of rehabilitating them to re-enter into normal life. So our training involves addressing each step of that process, from the acute care in the hospital to the outpatient and then back into normal life. So anything musculoskeletal, even including sports medicine, is within the scope of PM&R, focusing on the functional outcome.
Wonderful. Thank you. When evaluating a patient with chronic pain, what specific criteria do you use to determine whether they're a good candidate for interventional procedures versus more conventional procedures?
So this is where it comes back to understanding the how and why of their current situation. What is it that's driving the pain? Why has it not gotten better? And at the point they come to see me, it's usually not new onset. It's usually been present for some period of time, and they've usually even already seen other doctors and had other treatments done. So I'm really looking at the current picture. And at that time, there's often secondary processes. There's often buildup of feelings about their current situation. And so I have to unwind all of that. I have to reverse engineer all of that. So we're generally looking at treatment on multiple fronts. So I'm sort of screening big picture. Is there sensitization of the nervous system? Because when there's been pain going on for some period of time, the nervous system becomes sensitized. It tends to hold a grudge. It tends to be overreactive. Things that shouldn't otherwise be painful become painful. If there's sensitization, I have to treat that as a separate process. Beyond the sensitization, I have to identify the primary anatomic problems that continue to generate a pain signal. We have to understand why they're still generating a pain signal, and we have to treat that process. And then the third part is the psychological piece of it, having dealt with this, having frustration, anger, resentment, any feelings they may have about their current situation, their inability to work, the impairments on their relationships and their sense of self because they can't function normally. That just adds complexity to their treatment journey. So I have to become aware and assess each of these domains and figure out a treatment plan for each of these domains.
And for the audience out there, you can see from Dr. Siefferman's answers the depth of experience he has about this work and his passion, his real passion, plus his approach. What role do you see emerging technologies like neuromodulation, regenerative medicine playing in the future of interventional pain management, particularly conditions that have traditionally been difficult to treat?
So these are very much in play now, and I look forward to their evolution. When we think of neuromodulation is using an electrical signal to disrupt a pain signal. It doesn't necessarily fix the core problem. So when I'm working with a patient, I'm really looking to exhaust all physical sources of ongoing pain and treat those primarily. That's where the regenerative medicine often comes in, because there's often a structural defect that prevents the pain signal from stopping. So we start with that. We try to restore the anatomy. We try to optimize the anatomy. Once the anatomy is fixed as well as we can, then we try to desensitize the nervous system. And we do that with a combination of medications, nerve blocks, sympathetic blocks, stellate ganglion blocks, ketamine infusions, lidocaine infusions, have a whole slew of tools to desensitize the nervous system. If the nervous system desensitizes, great. They do their PT, they get back to work, everything's fine. If we cannot desensitize the nervous system, if no matter what we do, we cannot stop the pain generation or the sensitization from the pain generation, that's when we bring on neuromodulation. It's really a means of last resort because it's an implanted foreign body in the patient. And it's also not 100% effective. So there is a role for disrupting pain signals. There's a role for reprogramming the nervous system. Neuromodulation can do this. We can do it with spinal cord stimulation, dorsal root ganglion stimulation, peripheral nerve stimulation. There's a variety of different products available depending on what we want to target and how we want to target. And we can also escalate and shift between these if we need to. I explain this to patients early on because if they are frustrated, if they're suicidal, if they feel like they've tried everything and nothing works, but no one's discussed this with them, I explain this as an escape hatch. So we will go down this diagnostic process to see why the pain is not remitting. If we find things we can treat, great. That's the off-ramp. If we can't, there's always this other option of neuromodulation, which we can try. And we do it as a trial. Any of these nerve stimulators, we use them for up to 7 days to see if they work before implanting them permanently.
Lots of tools in your toolbox. How long, I'm sure there's a range, but how long do you typically work with a patient for?
So combination of how complex their situation is and how responsive they are to treatment. So some patients we see, we're able to identify on the first visit what's going on, why it's happening, because it's a constellation we've seen before. And we may try a treatment for them. And if they respond well to that treatment, it may just be a couple visits and they're back on track. This happens often with sports injuries, just because, and it can even be a chronic sports injury where no one's isolated the actual reason for it. Or I've seen this with chronic low back pain where they've been dealing with it for several years, but nobody actually identified the reason for it. And if we're able to identify that and treat it, we get them back and they're good and it's easy, they move on. Otherwise, there's often a diagnostic process where we have to filter through different candidates. So one thing I'll do on the first visit is really take a very broad view of the patient through physical exam, through imaging, through their history. Any anatomic structures that could be potentially responsible for the pain they're experiencing, we'll outline all of those, we'll prioritize them, and then we'll offer diagnostic blocks to rule them in or rule them out. And we sort of go through this diagnostic process to really understand which anatomic structures in play and the relationship between them. Because, as I said before, there's often a primary originator of the pain that leads to biomechanical compensation. People change how they use their body in response to that primary pain, which then causes secondary and tertiary pains. It may be the tertiary pain that brings them in. The primary structure may not even be a pain generator. We see this with hypermobility quite a bit. But we have to work through this process to really understand what the primary is, why the primary is driving it, and then find a treatment that will treat that. And sometimes we only know through treatment, if it works, that it was actually the primary.
Yeah, wonderful. And just for so the group knows, we're halfway through here, and I'm opening up the chat if people have questions. I'm sure people do. Let's switch to opioids. How do you approach the delicate balance between providing effective pain relief through interventional techniques while minimizing the risk of patients developing a dependency on opioids?
So 25% of the population will develop dependency to opioids, regardless of any other factors. There are screening tools we use that help us understand if there may be increased risk of dependence or addiction. Two different things, right? So dependence is the body getting used to the medication and relying on the medication. And if you stop the medication, they will have a withdrawal effect. as opposed to addiction, which is where people will adopt abnormal behaviors to obtain the medication. It can interrupt their life, their job, social relationships, things like that. In general, we know a few things about opioids now that we didn't know, 15 years ago. Number one, opioids make pain worse. So opioids activate the opioid receptors, which turn off pain signaling. And your body reacts to that by, guess what, making more opioid receptors. So that's how people develop tolerance, meaning the dose of the opioid becomes less effective with time. And it's also how they develop dependence. So the body adapts to the opioid, and with time, the pain actually gets worse because of the opioid. So we don't use opioids for chronic pain for this reason. We will still use opioids for acute pain, meaning after surgery, after an injury, or for brief periods for pain flares. A reasonable example is someone with endometriosis who has a flare for a week out of the month. They may benefit from a short-term use of opioids for that week. But in general, we try to avoid them.
Thank you. For patients whose conditions haven't improved with conventional pain management options, what approaches do you find most effective when integrating interventional procedures with physical therapy, psychological support, chronic complementary medicine, and such?
So this is generally where I think it hasn't worked because they haven't identified the source. And this may seem like a bit of ego, but I think, getting a different opinion, a different set of eyes may find something that was previously missed. Because in general, there is a reason for the pain. There are a few situations where pain becomes centralized, meaning it's just coded in the brain. When that happens, even the spinal cord stimulators don't work. The ketamine doesn't work, but it's a very rare situation. 97% of pain is mechanical, meaning it comes from the mechanics of the body, bones, joints, things like that, which means we can treat it if we can identify it. So it's just the process of isolating it, finding the reason for it, treating the reason for it, and then sort of going through all those other options we talked about before.
Thank you. A lot of questions are coming in, and we'll get to as many as we can. There have been a few questions about ketamine. Is there a stigma around it? Can you talk about your experience with ketamine infusions for chronic and severe CRPS? So would you talk about that a little bit, please?
Absolutely. So ketamine is a very old drug. It's been used in anesthesia for 50, 60 years. So it's well understood. And it's a drug that we're comfortable with because it's been around for so long. Its use for pain has been prevalent for the past 40 years or so. And it was used for pain before it emerged as a treatment for depression, which happened 10 or 15 years ago. Using it for pain, one of the biggest challenges are the studies that are available for chronic pain are all over the board. And if you look at the Cochrane review for ketamine for chronic pain, it wasn't really able to draw any meaningful conclusions just because the study techniques were so widely varied, meaning the dose of ketamine, the duration of ketamine, the frequency of ketamine, highly varied across studies. So my takeaway from this as a practitioner, and one thing that is very specific to pain anyway, and you may have even heard patients complain that they feel like the doctor's experimenting with them. It really is, each patient is an N of one. I may see the same disc herniation in 10 different patients, but it came to be 10 different ways. It has 10 different pain presentations, and it responds to treatment 10 different ways. So we really have to take each patient individually and look at the complexity of their situation and decide what's going to be the best treatment for them. I take that approach to ketamine. And my general starting point with ketamine is to give a test dose. And it's very small, like 10 milligram IV push. I want to see, number one, do they tolerate it? Some people, their blood pressure spikes. Some people have vicious nausea. Some people get super dizzy or it triggers a migraine. They can't tolerate it. I want to make sure they can tolerate it. Number two, I want to make sure it actually helps with pain. 10 milligrams IV will usually have some modulating effect on pain. So if it does, great. Then we know it's going to work for their pain. So if it helps with the pain and they tolerate it, then I will do a 45-minute infusion or IM or sub-Q dose, depending on the situation. And that will be an initial treatment, and we'll see how they respond to that. I'm looking for how much pain relief they get from the ketamine itself, how much of a mental effect it has on them, both in terms of mood, but in terms of brain fog, concentration as well. The analogy I'll tell patients, it's almost like shaking their Etch-a-Sketch. So they've been drawing these patterns and making connections in their brain for all this time. A lot of these lines that they've drawn are not helpful. It's maladaptive. And that's what happens with chronic pain. So we kind of want to shake that Etch-a-Sketch. But they will also feel a bit shaken in the brain for the rest of the day, maybe even into the next day. So we want to baby step our onboarding of ketamine to make sure they tolerate it, make sure they're okay with it. Some people don't like the feeling, and it's not a fit for them for that reason. So after the initial treatment, I want to know how much better they are. I want to know how long that lasts. I want to know which pains it helps with and which pains it doesn't help with. Generally, these patients have multiple sources of pain. And then from there, we can decide, do we change the dose? Do we change the duration? And we will tailor fit for them.
Wonderful. Really helpful. We have a lot of questions coming in. We're going to try to get to them. Can you talk for a minute about medical cannabis? Is that something you incorporate? Where does that sit in your practice?
So I will be fully honest. My knowledge here is limited. I can tell you about the study for Marinol. So Marinol is a prescription version of THC that came out many years ago for nausea, anorexia associated with cancer chemotherapy. It has been studied for multiple sclerosis pain, which is a kind of central nervous system pain. And they actually found, comparing 2.5 to 5 to 10 milligrams, the lowest dose, the 2.5 milligrams of THC, was actually more helpful for pain than higher doses. So this is the advice I give to patients, and I've had patients reflect this to me also without asking for it. Usually the lower doses are more helpful for pain. Some of the challenges become function, right? So pain limits people's function, but they also want to be able to function, and THC limits people's function. So they have to find a time and a place that's helpful to use it. So, generally when they're at home and they don't have any responsibilities like childcare, they don't have anything else to do. If it helps them with sleep, great. So it's really finding the utility of it. So I don't have any aversions to it. I'm very much open to patients trying it, but I advise that they start with a low dose, try it at home when they have nothing else to do, see how they respond, and then adjust from there.
Thank you. Thank you. In dealing with, these are more questions coming in dealing with pain management, how do you navigate a conversation on a person's expectations for pain relief with realistic functional goals? How do you help people define what's an acceptable symptom state actually means for their daily life?
So with a lot of patients, I don't know what's going to happen. I don't know how they will respond to treatment. And I don't try to guess or make promises. One thing I've learned in medicine is certainty is uncertain. So I do my best to share my awareness with the patient, what I see in terms of what I see going on with their bodies, what we can do for those different things, and what their expectations with each treatment might be. And so I kind of leave it at that. And, again, this goes back to the experimentation thing because everyone's individual. This makes sense to try for your situation. We can try it. These are the risks. These are the benefits. We'll see what happens based on your response. We will then have better understanding of what's actually going on and what you respond to, for better or for worse. Sometimes we'll do diagnostic injections and the patient flares. If they flare, that gives me some understanding of another process going on in their body that led to the flare, which redirects our focus to treat that first. So it's really an iterative, step-by-step process, and we learn about each individual patient as we go down this pathway.
Thank you. We're getting more questions about what different tools you're using. Can you speak about Gervanox and potential within your practice?
Yeah, so this is a cool new tool because it targets a pathway that hasn't been targeted before. So for a lot of patients who, especially the ones who've been dealing with a pain for many years and who have gone down this, mechanical diagnostic pathway and either can't get an answer as to what's causing their pain, or they have an answer, but the solution is not reasonable. So for example, like thoracic disc herniations, excruciatingly painful. Thoracic disc surgeries are really not recommended. It's very difficult surgery and the outcomes are not great. So it's a difficult situation to treat. This is where before we would lean towards something like a spinal cord stimulator, which even then is not an amazing treatment for it, but it's kind of the best we had. This is a situation where the newer medication can be helpful. And so most insurances will cover it now for acute pain, meaning new onset pain. So we need some legitimate reason to give it to them for acute onset pain, which can be post-procedure pain, and they will generally cover it for 2 weeks. So they can get a 2-week trial, try it for 2 weeks, see what happens. If it's helpful, that's fantastic. But then the limitation is getting it for a longer period of time. And of course, for those with means, they can pay for it, like roughly $2,000 a month, I think, depending on the sourcing. But otherwise, getting insurance to cover it for a longer period for chronic pain